Hi, my name is John Pandolfino, and it's my pleasure today to be giving you the talk, The Approach to Esophageal Patients, Optimizing Index Endoscopy. Now, although the approach to typical esophageal symptoms like heartburn, regurgitation, dysphagia, chest pain, and food impaction can at first seem very complex because there is a vast differential diagnosis like gastroesophageal reflux disease, EOE, obstruction, a motility disorder, or potentially a functional problem, it's actually quite simple because regardless of what I think and the history that I take, almost all roads are going to lead to endoscopy, and if that is negative, further diagnostic testing. Endoscopy is crucial to rule out a mechanical obstruction or a reflux injury or EOE. And then, of course, if a negative endoscopy is encountered, which is about 50 to 70% of the time, we will have to go through a process or an algorithm that will require further testing. Now, the problem is that when you use this particular test and you don't optimize that index endoscopy, it can sometimes take 6 to 12 months to get a final diagnosis for many of these patients. And this gets us to the core of the talk today. As I mentioned, 50 to 70% of the endoscopies that we perform in patients with esophageal symptoms tend to have either a negative diagnosis or a non-diagnostic and will require additional testing. That means that the other 30 to 50% of the time, you'll need additional testing. And really, that should not be looked upon as a weakness. It should be looked upon as best practice. Because if you apply something I like to call Fontana's Law, named after Brian Fontana, a character from Anchorman, who had the very famous quote, 60% of the time it works every time. If you apply that process, if you do tests that are about 60% certain multiple times, eventually you will get the right answer 80 to 90% of the time after doing those tests. And if you can expedite those and perform many of those during that index endoscopy, you will be providing the patient with value-based healthcare fast. Now, this is highlighted on this standard algorithm for esophageal symptoms. Patients may come in with esophageal symptoms. If they have dysphagia or any warning signs, they'll get urgent referral for endoscopy. If they don't, and they have chest pain, heartburn, or maybe something like globus, they may attempt a PPI trial if there are no warning signs on history or physical exam to suggest either a cardiac issue or a GI malignancy. Now, maybe after a 2 to 3 month PPI trial, if they're not getting better, those patients will be referred for an endoscopy. If they do respond, they'll be treated accordingly, and you may consider endoscopy for screening for Barrett's, specifically if you think this is underlying reflux. Now, as I mentioned, a good portion of the time, maybe 50% of the time, we find a good diagnosis on endoscopy. We're pretty certain what's going on. They may have something like eosinophilic esophagitis or erosive peptic esophagitis. And then, of course, we diagnose that and we treat it. Now, many times, though, these patients have a negative exam, and it does require further testing. And that could be either with reflux testing if you're really focused on heartburn or maybe regurgitation, or potentially motility testing if you're thinking that this is more dysphagia and you're trying to rule out achalasia. Regardless, that usually delays the diagnosis. And then by the end of all of this, you wind up spending 6 to 12 months to get a final diagnosis of maybe a major esophageal motor disorder or a functional diagnosis, or even confirming that they truly have gastroesophageal reflux disease. Now, what if you could bypass that and actually go through this process in a much more streamlined fashion? What if the patient comes in with esophageal symptoms, they get referred for endoscopy, you evaluate them, and once again, if you find an overt cause, you treat that accordingly. But if you don't find anything, you actually, right then and there, during that index endoscopy, have the patient undergo a flip panometry, where you can then assess the patient for a major esophageal motility disorder. And if they have signs or symptoms of achalasia, treat them right then and there. If they actually have no evidence of a major motor disorder, they may have some weak peristalsis and normal opening of the esophagogastric junction, you could perform wireless pH capsule testing right then and there, and then get through all of this process in less than a week and basically diagnose almost every diagnosis within your differential diagnosis in the span of about 96 hours to 1 full week. That is really the paradigm shift that we're looking at with upfront index testing with flip panometry. And this strategy that I'm suggesting is a paradigm shift, and we like to call it endomapping with panometry. What we do is we perform a good endoscopy, rule out the overt causes of mechanical obstruction, abnormal anatomy, and inflammation, then perform something called a CAR score that we'll cover in a little bit more detail, which gives us an ability to stratify risk of a major motor disorder or achalasia. The patient will undergo flip panometry, where we'll assess their underlying esophageal motility and obstruction level, or whether or not there is normal opening at the esophagogastric junction. We can find strictures, and then we will analyze that data using the Dallas consensus using a technique we call MECView. Now, as I alluded to in the previous slide, one of the first things that we do after we rule out overt causes on endoscopy is to assess their CAR score, which gives us an idea of whether or not these patients actually have achalasia. We do this by doing a careful inspection of the esophagogastric junction, looking for the degree of resistance and whether or not there's puckering and a resistant or obstruction at the esophagogastric junction. And then, of course, we're looking at the body of the esophagus to see whether or not there are any contents, liquids, saliva, or even food, and then the anatomy to look to see what the level of dilatation is, and then of course if there's any evidence of non-peptic esophagitis like stasis esophagitis or potentially candida esophagitis. So how does the CAR score work? Well, as I mentioned, CAR stands for contents, anatomy, resistance through the LES, and stasis. And we actually grade that depending on whether or not it's completely normal, whether there's some intermediate findings and severe findings. And based on that particular score, we're able to, with a high degree of confidence, rule in achalasia and even give a very low probability of achalasia with this particular scoring system. So for instance, if a patient actually has a CAR score equal to or greater than 4, the likelihood ratio that these patients actually have achalasia is 48. You're almost confident 100% that these people have achalasia. Now, if their CAR score is 0, the interval likelihood ratio is 0.06. So once again, you've almost completely ruled out achalasia in that particular point, which is extremely important because that can inform your flip panometry and give you absolute certainty on the ends of the spectrum, whether someone has normal motility or someone truly has achalasia that would require treatment. Now, as many of you already know, the EndoFlip catheter is an actual device that can give you basically an understanding of the motility of the esophagus by causing a distension-mediated contractile response, which typically is either normal propagation from the top to the bottom in the antegrade direction. Maybe there's absent, no motility, or even retrograde motility. It also gives you a nice estimate of whether or not the patient actually has normal opening or extremely abnormal or reduced EGJ opening, which is more consistent with an EGJ outflow obstruction or obviously achalasia. Now, going through this particular process and this particular algorithm is something that was just recently published as the Dallas consensus, looking at a combination of taking the EGJ opening dynamics and then looking at the contractile response. And in doing that, you can actually diagnose the underlying esophageal motor function or dysfunction in that particular patient. So once again, you're placing the flip catheter through the esophagogastric junction. You're getting evaluation of the esophagogastric junction opening and resistance. And then, of course, you're looking at these patterns of peristalsis that can either be absent, spastic, normal with repetitive antegrade contractions, and so forth. And then using that data in this particular table to provide a Dallas consensus diagnosis, which gives you the probability of having normal function, potentially reflux, or achalasia. So now I know we went through this pretty quick, but I'm going to rehash this with this big review slide here that actually shows how I do things day in and day out when I'm dealing with patients in my clinic. So as you can see, the patients come in with esophageal symptoms. As we mentioned, if there are urgent warning signs or cardiac cause, we'll refer them appropriately. But once we get them into the endoscopy lab, I will obviously rule out the overt causes like esophagitis, eosinophilic esophagitis, anatomical or other mechanical issues. I'll then perform a CARS evaluation, which gives me a pre-test probability of a major motor disorder or the lack of a major motor disorder. And then I will perform flip panometry. Of course, we're always getting biopsies in patients who have dysphagia just to rule out EOE, although I will tell you that the likelihood of having EOE if you have essentially a normal endoscopy and a normal flip is going to be very, very low, but nonetheless we do it because there are occasional patients that we may miss. Now, once we're done with the flip panometry, we look at the patterns and the opening dimensions, and typically patients fit into one of 6 buckets, either normal, hypocontractile, a possible obstruction, possible spasm, a spastic obstruction, or a non-spastic obstruction. So now we're going to start on the ends. So if you see a patient that actually has a normal pattern, the rack pattern with these repetitive antegrade contractions, and they have normal opening, most likely these patients have either GERD or a disorder of gut-brain interaction. So you can perform wireless pH testing, depending on whether it's positive or negative, diagnose them with GERD or without GERD, and depending on what their symptoms are. Potentially, if everything is negative, these patients have a disorder of gut-brain interaction. Now, on the other end of the spectrum, say the patient has this particular pattern, a non-spastic obstruction. They have no opening at the esophageal gastric junction or severe restriction, an absent contractile response. Say their CAR score is greater than 4. You're done. You've diagnosed achalasia. The likelihood that these patients don't have achalasia is almost 0. These are patients that you can actually treat right then and there with either a POEM, if you're set up for that, or a pneumatic dilation. Now, of course, if there's conflicting evidence, maybe the CAR score is not greater than 4, maybe it's 1 to 2, and you're considering that there's a potential that this might be a spastic motor disorder or a spastic variant of achalasia, then in those particular patients, you can refer them for high-resolution manometry, understanding that most likely they have a diagnosis of achalasia. Now, as we go more into the middle here, here's a patient who has weak peristalsis or weak contractile response and normal opening at the esophageal gastric junction. This patient may have normal motility or IAM. Regardless, this is most consistent with GERD physiology. And once again, these are patients that you would perform wireless pH testing with either the Bravo or Alpha capsule. And depending on what the results are there, you would treat these patients as either having reflux or potentially having a disorder of gut-brain interaction. Now, there were some people who say, well, maybe they have severe IEM. Well, typically those patients will have a completely absent contractile response, and those patients may respond to a motility agent, but once again, I leave manometry in these patients to the absolute end if I can't take care of them by managing their reflux and lifestyle modifications and behavioral therapies for the DGBI. Now, if a patient has this particular pattern, a spastic obstruction, their CAR score may show some abnormality, some resistance through the esophageal gastric junction, these patients likely have a disorder like type 3 achalasia or a spastic motor disorder. You can refer those patients for high resolution manometry with the confidence that this person has something abnormal that you need to address. You can talk to the patient afterward and explain why they need to undergo the high resolution manometry. Now, patients who have something like a possible obstruction, they may have a little bit of resistance through the esophageal gastric junction. They may have a pattern of absent contractile response. You may suspect that there's a slight possibility they could have achalasia or there's a mechanical obstruction here. These particular patients, you would do targeted dilation using the max diameter and distensibility plateau that you've defined during flip. So once again, being able to manage the patient in that particular index endoscopy. And of course, if you dilate the patient, you see a disruption, you've obviously uncovered a stricture. If there's no disruption, these are patients that may need a manometry in the end. Similarly, if someone has a possible spasm or kind of a jackhammer pattern, they have retrograde contractions, those are also patients that you can be comfortable sending for high resolution manometry. So remembering the Fontana law, if you have these patients that you're certain who have normal motility or a definite diagnosis of achalasia, that happens at least 50% of the time when we're taking care of these patients. You can confidently treat these patients and make sure that they're getting the most effective therapy. And then in the ones that are in between, you do further testing and then come up with a diagnosis. But at least you've given that patient the opportunity to maybe not undergo a painful manometry. And also you've expedited this workup by ruling in and ruling out multiple other possible disorders. So let's look at this a little bit more granularly. So say we have a 48-year-old woman with dysphagia and globus for 3 months. Perception of food caught in the chest, solids worse than liquids, no regurgitation or heartburn. A 5-pound weight loss, some increased stress, fearful of eating, no improvement on PPI. Do the patient's endoscopy, essentially normal, no contents, not dilated. EGJ looks pretty normal. So CAR score is 1. You perform flip panometry, you see a beautiful rack pattern with normal opening. The Dallas classification based on these particular parameters suggests that this is normal. This patient undergoes wireless pH testing using Lyon 2.0, especially if the patient is suspected of having reflux. You could even make the diagnosis of functional dysphagia at that particular point. But given the fact that the patient didn't respond to PPI, it may be better to just rule out reflux in this particular instance. And then within the span of 7 days, you will have actually given the person a precise diagnosis and a personalized approach. And now this patient will understand why you're attempting lifestyle modification and treatment with neuromodulators and behavioral medicine. Now I'm going to switch things up here a little bit. Now say that same patient, when we actually perform their flip panometry, has a pattern that is consistent with non-spastic obstruction. They have distensibility index of 1.2, a max diameter of 8.5, probability of obstruction is 87%. They get a diagnosis of non-spastic obstruction, which typically is either type 1 or 2 achalasia. Now, of course, in this particular example, you probably still get endoscopic biopsies. And the question now comes in whether or not you really need an HRM. In these particular examples, I personally do not get a high resolution manometry. I think that this is pretty classic achalasia. That's a pretty classic presentation in terms of the flip panometry. There's nothing to suggest pseudoachalasia. There's no large hernia that could potentially give you a false positive. I think it is very reasonable to approach this patient and provide them with definitive treatment for their achalasia. And in this particular patient, I would schedule them for a pneumatic dilation. Now, some people would say, why didn't you do POEM? Well, this particular patient, I think I can treat endoscopically pretty easily, has a very straight esophagus, and I think pneumatic dilation still has a very nice place in the armamentarium of how we treat achalasia. So what about a different patient, 37-year-old man with dysphagia and heartburn for 2 years, perception of food getting caught in the chest, has nocturnal regurgitation, unpredictable burning in his chest. Kind of consistent with achalasia, 15-pound weight loss, no improvement on PPI. You do the endoscopy, significant dilatation, lots of liquid, resistance through the esophageal gastric junction. You can see some puckering here. So this CAR score is greater than 4. You're almost certain this person has achalasia. Do you really need to bring that person back and have them undergo a manometry? Absolutely not. You do a flip panometry, you diagnose non-spastic obstruction in this particular patient, the EGJ is tight, you make MEC-view measurements, and you provide them with a Dallas classification diagnosis of a non-spastic obstruction in someone with a CAR score greater than 4. This is achalasia, non-spastic, either type 1 or type 2. And basically just looking at that particular endoscopy, you know this is dilated. It's most likely type 1. Doesn't really matter whether you give it a diagnosis of 1 or 2. This is someone who should be referred for definitive therapy with either pneumatic dilation or POEM. So in conclusion, I want to bring us back to Fontana's law. 60% of the time it works every time. Now I like to think of it more, I can diagnose people 100% of the time, 50% of the time, meaning that I can actually get to the right diagnosis in most of the patients. On the surface, this statement appears to be somewhat nonsensical. Yet in diagnostic testing, it reflects a paradoxical truth. A test may be completely reliable in certain situations on the extremes. You can confidently roll things in or out. So if something has a positive predictive value of 100%, you don't need any more tests, you're done. If something has a negative predictive value of 100%, you've ruled out that major disease state that you want to. This is the essence of Fontana's law in diagnosis. You can be absolutely confident in positive and negatives at the extremes. So once again, endoscopy is a test that you can be very confident in terms of the positives and then in the negatives. You can rule things out and rule things in. And then taking a second test like flip panometry or potentially another test on top of that, wireless pH monitoring, or eventually even mucosal integrity, using this idea of Fontana's law being certain at the extremes, you will get to the point that you can make a confident diagnosis in 90% of your patients. And the beautiful thing is that if you leave this to the index endoscopy, you will be done in essence in less than a week. Diagnoses that take 6 to 12 months to get to, we can now get to in a week. That has to be cost effective, not just monetarily, but in terms of patient satisfaction. So thank you very much for your time.